আজকে যেটা পড়াবো সেটা হচ্ছে থেরাপিউটিক্স অফ নিউমোনিয়া অর ম্যানেজমেন্ট অফ নিউমোনিয়া। ওকে, সো আমি আগের ক্লাসগুলোতে তোদের একটা ব্রিফ আইডিয়া অফ নিউমোনিয়া দিয়েছিলাম। হোয়াট ইজ দ্য প্যাথোজেনেসিস অফ নিউমোনিয়া, হোয়াট আর দ্য ডিফারেন্ট টাইপস অফ নিউমোনিয়া অ্যান্ড হাউ ইউ ডায়াগনোজ নিউমোনিয়া, রাইট? সো এখান থেকে কিছু এমসিকিউজ আছে, এগুলো অ্যাটেন্ড কর। So 60 years old diabetic lady admitted with history of low grade of fever. So this is the X-ray and diffuse chest pain with dry cough. Hemoglobin is low and LDH is 890. Okay, so LDH is high and hemoglobin is low. And this is the X-ray. So what could be the probable etiology? Streptococcus, staph, mycoplasma or Legionella? What is the probable etiology? First of all, this is not a lobar pneumonia. This is not a lobar pneumonia. This is interstitial pneumonia, right? And hemoglobin is 8.6 along with LDH is 890. Although এখানে সবকটা information নেই, but suspect this is a case of AIH, autoimmune hemolytic anemia, right? Because of this pneumonia. So, what could be the etiology? Hemolytic anemia with pneumonia. Most common is mycoplasma. Okay, so this is a mycoplasma pneumonia. Second, urinary antigen detection is recommended in which pneumonia? Pneumococcus, right? And direct fluorescent antibody test helps to detect which organism? Is it pneumococcus, staph, Legionella or chlamydia? Chlamydia and other organisms, chlamydia, pneumococcus and pneumocystis carinii. These three are the organisms which can be detected via DFAT. So 58 years diabetic alcoholic male with history of cough with mucopurulent expectoration, and this is the X-ray. So this is typical of which pneumonia? No, this is Klebsiella pneumonia. Why? Because this is a, what is this? Yes, this is bulging fissure sign. So this is Klebsiella. So 68 years old male having fever and cough with mucopurulent expectoration. He is confused. He is tachypneic and BP is 120/60. Saturation is 94% in room air. So what will be his site of primary care? Can I ICU? Why? Score কত? CRB 65 score কত এই পেশেন্টের? C for confusion, right? So he is confused. 1. Next, respiratory rate is 36. It is obviously more than 20. That is 2. And 65 is 65 years of age. More than 65, 68 years of age. So this is, the score is 3. So if the score is 3, that is more than 2, the place of initial treatment should be in ICU. Next, treatment protocol of community acquired pneumonia. So actually community acquired pneumonia, management of community acquired pneumonia consists of treatment and site determination, that is to be determined by the CRB 65 score, and to determine the severity of pneumonia. Is the pneumonia severe or non-severe? So place of treatment, that is you should assess by CRB 65 or CURB 65. So nowadays urea cannot be estimated in bedside. So CURB 65 score is replaced by CRB 65 because it is more feasible to assess. Next, severity assessment. So what are the severity criteria of pneumonia? I have taught in your previous class. What are the severity assessment criteria of pneumonia? So the major criteria involves any one of the major criteria, that is the patient with pneumonia requiring mechanical ventilation or patient requiring vasopressor to elevate his BP, blood pressure, or any three of the minor criteria, that is respiratory is more than 30, PF ratio is less than 250, there is multilobar infiltrate, patient is confused and having uremia or leukopenia, thrombocytopenia, hypothermia. So these are the minor criteria. Among those minor criteria, if three of the criteria are fulfilled or any one of the major criteria is fulfilled, then you can call it as severe community-acquired pneumonia. So direct admission to ICU is required for the patients with septic shock requiring vasopressor support or with acute respiratory failure requiring ventilatory support. And next, you should assess if the patient is having any risk of multi-drug resistant organism. So what are the risk factors? Most important risk factor is previous isolation of MDR. If the patient was admitted previously in your or other hospital's ICU and you found that the patient was having MDR organism, multi-drug resistant organism, then this time also the patient may have MDR organism. The second important thing is immunocompromised state, uncontrolled diabetes mellitus or any other immunocompromised state, old age and IV drug abusers. Third point is if the patient have received any broad spectrum antibiotic in past 3 months, home antibiotic infusion, or the patient is CKD patient with having dialysis. So these all are the risk factors for MDR organisms. So what could be the initial OPD treatment? Any idea? Any idea? What could be the regimen? So the initial regimen for healthy OPD patients without any comorbidities. Comorbidities means the patient is having any chronic lung disease, any chronic kidney disease, chronic liver disease, or any other systemic diseases, or the patient is not immunocompromised, or the patient has not asplenia or not splenectomized patient. So these all patients are categorized into patients without comorbidities. So the recommended regimen is amoxicillin tablet, this is oral form, amoxicillin 1 gram thrice daily or doxycycline 100 mg twice daily in case of patients who are resistant to amoxicillin or who are intolerant to amoxicillin, right? So amoxicillin, which class of drug, which class of antibiotic? Beta-lactam. So what is the mechanism of action of amoxicillin or beta-lactam? So actually they alter the binding site, PBP, penicillin binding protein, right? So they alter the site and hinder the cell wall synthesis, right? So PBP binding protein inhibitor. And doxycycline, which class of drug? So this is a tetracycline group. So tetracycline, which is the mechanism of action of tetracycline? 30S ribosome inhibition, right? Or a macrolide, that is the most, আমরা যখনই কোনো পেশেন্ট কোনো আমাদের একটা ভাইরাল ফিভারই হলো, 3 days একটা ভাইরাল ফিভার আমাদের স্টে করলো, গলা ব্যথা হলো, সোর থ্রোট হলো, আমরা মেডিসিন কাউন্টারে গেলাম, আমাদের কি দেয়? মোস্ট কমন অ্যান্টিবায়োটিক ইউজড অ্যাজিথ্রোমাইসিন, রাইট? সো এটা উচিত, মানে দিস ইজ নট রাইট, বিকজ if this drug will be resistant, then there will be a big problem. Okay, so azithromycin actually অনেক OPD ট্রিটমেন্টের প্রোটোকলে আছে, like CAP management. Azithromycin is more preferable than clarithromycin than erythromycin because the penetration of azithromycin in lung tissue is more than clarithromycin. And for OPD patients with comorbidities such as chronic lung, liver or renal disease, diabetes mellitus, alcoholism, or immunocompromised individual, or the patients with asplenia. Why? Why asplenia? Why I have mentioned asplenia? Or splenectomized patient. What are the risk factors of the splenectomized patient? Why I have mentioned splenectomized patient? Because splenectomized patients, there is a high chance of pneumococcal pneumonia. Right? Because why? Yes, this is an encapsulated organism. And another encapsulated organism, Neisseria, right? So in those patients, we prefer giving amoxicillin clavulanic acid. Why we should add clavulanic acid? What is clavulanic acid? So mention the resistant factors of beta lactam. Most common resistant factor. কিভাবে resistance হয় beta lactam? Beta lactamase inhibitors. So the most commonly the gram negative bacteria produces beta lactamase. So which inhibits the action of beta lactam, right? And they disrupt the ring of beta lactam antibiotics. So this is a beta lactamase inhibitor because we suspect high resistance of beta lactam in those patients because এই patient যারা আছে এগুলো এদের কি হয়, there is a high chance of drug resistant organism because they are having these comorbidities. So amoxicillin clavulanic acid or cephalosporin. So cephalosporin again is which group of drug? Beta lactam. So most preferable cephalosporin is cefodoxime or cefuroxime. Cefodoxime is which class of cephalosporin? Cefuroxime class 2 and cefodoxime class 3. So what is the difference between class 2 and class 3? In which term? More broad spectrum in which term? Yes, gram negative. So class 3 offers more protective action against gram negative organisms than class 2, right? And class 4 and class 5 along with these same organisms like gram negative, gram positive and additional coverage. No, pseudomonas. Yes, additional pseudomonas coverage. Plus macrolide or doxycycline or to cover the atypical organisms. Macrolide to cover the atypical organisms like which are the atypical organisms? Mycoplasma, Legionella, etc. Or monotherapy with respiratory fluoroquinolone. So what is the mechanism of action of fluoroquinolone? Yes. So what are the respiratory fluoroquinolones? There are 3 respiratory fluoroquinolones. There is levofloxacin, moxifloxacin and gatifloxacin. Okay. And gemifloxacin also. But we avoid using levofloxacin or any other kinds of fluoroquinolone as a first line drug therapy. Why? Because they are the anti-tubercular drugs also. So আমরা যদি বেশি করে fluoroquinolone use করি, so কি chance বাড়বে? There is chance of anti-TB drug resistance. Okay, so আমরা কিন্তু they are the reserve drugs, levofloxacin, moxifloxacin. So inpatient treatment, patients with non-severe CAP. Non-severe CAP, what is the definition of non-severe CAP? What is severe CAP? আমি এক্ষুনি slide দেখালাম. What is severe CAP? This is very important in your practice also. What is severe CAP? What are the diagnostic criteria of severe community acquired pneumonia? Hypotension and yes, any one of the major and other 3 of the minor. Okay, so in case of non-severe CAP and the patient not having risk factors for MRSA. What is MRSA? Yes, for MRSA or MDR organisms. So IV combination with a beta lactam, that is same amoxicillin clavulanic acid or cefodoxime and a macrolide or doxycycline. So the same OPD treatment will be converted into IV treatment. or a respiratory fluoroquinolone, that is most preferably oral or IV, levofloxacin, moxifloxacin or gemifloxacin. And patient with severe community acquired pneumonia, beta-lactam plus macrolide, or the most preferred regimen is beta-lactam plus respiratory fluoroquinolone, that is not or respiratory fluoroquinolone, beta-lactam combined with a fluoroquinolone. And also beta-lactamase inhibitor, not only beta-lactam, beta-lactam with beta-lactamase inhibitor plus fluoroquinolone or macrolide. Patients with influenza pneumonia, out at these patients H1N1 or H5N1, any one of the pneumonia, influenza pneumonia. So, toder ki idea? What is anti-influenzaal drug? Yes, very good, oseltamivir. So, what is the mechanism of action of oseltamivir? Yes, neuraminidase inhibitor. So, oseltamivir 75 mg twice daily. This is the preferred regimen. And patients having severe pneumonia with risk factors for MRSA. So, what are the risk factors for MRSA? Ki risk factors আছে তোদের কি আইডিয়া? কাদের MRSA হওয়ার চান্স বেশি? First, IV drug abuser. Second, patients having infective endocarditis, immunocompromised individual, chronic kidney disease in dialysis, right? And previous antibiotic user in last 90 days. Prior MRSA isolation, যেটা আমি একটু আগে বললাম, prior MRSA isolation or MDR organism isolation, and MSM, male sex male, immunocompromised individual, household exposure of MRSA patients. একটা রেজিমেন আছে, বেসিক্যালি আগে একটা স্টাডি আছে যেটাতে বলা হয় যে MRSA colonizes in nasal hair most commonly. তো যে পেশেন্টদের হাউসহোল্ডে আগে অন্য কারোর বাড়ির লোকের MRSA আইসোলেট হয়েছে তাদের অ্যাজ এ প্রোফাইল অ্যাক্সিস উই yes, mupirocin nasal ointment we use, okay, to decrease the risk of MRSA exposure. And what could be the management? And what are the anti-MRSA drugs? Vancomycin. So vancomycin is a type of which antibiotic? Class of which antibiotic? So it is a glycopeptide, cell wall inhibitor, right? Vancomycin. So this is the dose 15 mg per kg, 12 hourly, but should be adjusted on the basis of creatinine level. So in patients having CKD stage 4 or 5, so we should avoid vancomycin. We should prescribe linezolid, right? And next, severe pneumonia with risk factors for Pseudomonas. So what are the risk factors for Pseudomonas? What are the risk factors of Klebsiella? আগের ক্লাসে পড়িয়েছিলাম. What are the risk factors for Klebsiella? What are the risk factors of Klebsiella pneumonia? Alcoholism. Second, immunocompromised individual. Third, structural lung disease. This is very important. Structural lung disease, that is cystic fibrosis, bronchiectasis. These patients harbors Pseudomonas and Klebsiella in their airway. Okay. So antimicrobial therapy in prior 3 months. So this is the antimicrobial therapy in past 3 months. This is the most important risk factor for any MRSA or MDR organism. যদি পেশেন্ট লাস্ট 3 মান্থসে বাড়িতে হতে পারে বা হসপিটালে ব্রড স্পেকট্রাম অ্যান্টিবায়োটিক নেয়, so there is also a chance of MRSA or MDR organisms. Frequent COPD exacerbations, other structural lung disease. So in case of patients with pneumonia with having risk factor of Pseudomonas, what are the anti-pseudomonal drugs? Anti-pseudomonal antibiotics. First, beta-lactam. Beta-lactam কি বলি, beta-lactam কি আছে? First, piperacillin tazobactam. Second, okay, next aztreonam. Next, third, actually If we combine third generation antibiotic with a beta lactamase inhibitor, then it is anti-pseudomonal. Avibactam. Okay, next, আর কি আছে? Among fluoroquinolone, levofloxacin, ciprofloxacin. Not moxi, levo and cipro. Next, aminoglycoside, amikacin, tobramycin. So these are the anti-pseudomonal antibiotics. So piperacillin, tazobactam or cefepime. Cefepime is which generation of? Fourth generation of cephalosporin. And ceftazidime with avibactam combination. Aztreonam combined with aminoglycoside or anti-pseudomonal fluoroquinolone, cipro or levo. Aspiration pneumonia. So what are the most common sites for aspiration pneumonia? What are the most common sites for aspiration pneumonia? কোন এরিয়াতে নিউমোনিয়া হলে তুই সাসপেক্ট করবি? Yes, there may be this is maybe a case of aspiration pneumonia. কোন এরিয়াতে? লাংসের কোন এরিয়াতে? First, posterior segment of right upper lobe and anterior segment of right lower lobe. Okay, why there is a chance of increased aspiration pneumonia in these segments? কেন রে? বেসিক নলেজ থেকে বল, অ্যানাটমি কি বলছে? First, second, bronchus, right bronchus is yes and 90-degree angle. So there is every chance of aspiration more than the left one. So in case of aspiration pneumonia, in any patients, routine coverage of anaerob we do not recommend. But in case of aspiration pneumonia, if it is evident that the patient is having aspiration pneumonia or necrotizing pneumonia or lung abscess, then the drug of choice is clindamycin. But if the patient is not tolerating clindamycin, so what is the most common adverse effect of clindamycin? Yes, pseudomembranous colitis. So if the patient is not tolerating clindamycin or allergic to clindamycin, we may give amoxicillin clavulanate. So what could be the ideal duration of antibiotic? Most commonly in patients with CAP requiring ICU admission, the antibiotic duration should be 7 to 10 days. But recently একটা ট্রায়াল পাবলিশ হয়েছে নিউ ইংল্যান্ড জার্নাল অফ মেডিসিনে, তাতে they have recommended not to prolong the antibiotic for more than 7 days. There is no benefit of prolonging the antibiotic for more than 7 days despite in specific situations like কি situation? Necrotizing pneumonia or patient having lung abscess, then the antibiotic therapy may be for duration of 14 to 21 days যতক্ষণ আমরা radiological resolution of abscess দেখতে পাচ্ছি. So when to stop IV antibiotics? So IV antibiotics you cannot, তুই মানে একদম টানা 7 days কি 14 days তুই তো দিতে পারবি না. So you must switch to oral therapy. So what is the when you should stop IV antibiotic and switch to oral? So when the patient is able to tolerate the solid food and the patient is afebrile, so these are the criteria when you would like to switch from IV to oral antibiotic. So resolution is of two types, clinical and radiological. So clinical resolution comes first followed by radiological resolution. Clinical resolution মানে হচ্ছে the patient is afebrile, right? The patient is able to eat, the lost appetite is regained. So these are the criteria of clinical stabilization. And radiological resolution, আমি আগের ভিডিওতে একটা এক্সরে দেখিয়েছিলাম, আমি আবার দেখাচ্ছি দেখ. And the temperature in patients with pneumococcal pneumonia usually starts to fall within 24 to 48 hours of commencement of an appropriate antibiotic. So this is very important. So also the patients will able to eat and vital signs will be normal. So So this is the criteria of clinical stabilization. And what are the criteria of failure to improvement after 5 days of antibiotic? Jodi kono patient after giving 5 days or 7 days of antibiotic, the patient is not improving enough. So toder ki diagnosis aste pare, ki hote pare? So there might be a sudden complications of pneumonia, developing complications of pneumonia. Second thing, the organism mostly is not sensitive to that antibiotic you are giving, okay, and the antibiotic choice is not perfect, and the dose is not proper. If the patient is immunocompromised or the patient is having CKD, you must modify the dose, and in obese patient you also modify the dose according to the body weight. So other diagnosis like which mimics the pneumonia, like malignancy, interstitial lung disease. Complications of pneumonia like lung abscess or empyema. What is empyema? What is empyema? Pus in pleural cavity. This is empyema. And what is lung abscess? আগের দিন তুই তো বলেছিলি, ডেফিনিশন কে বললি বল? Actually, long-term infection causing parenchymal damage which results into cavity formation. This is lung abscess. And the rate of radiographic clearance is 80% within 12 weeks. কত delayed resolution হয় দেখ তাহলে, তাই না? তুই একটা পেশেন্টের ফিভার কমে গেল, তারপর এক্সরে করলি, this is not good, right? So এক্সরে করতে হবে after 2 weeks. There might be a resolution of 25% after 2 weeks, and after 3 weeks the resolution is 35%. And most of the pneumonias, if it is not complicated or if it is not due to MDR organisms, they radiologically are cleared within 3 months. 80% are cleared. So this is initial X-ray, and this is the X-ray after 3 weeks, right? So this is the resolution. So what is defined as non-resolving pneumonia? So non-resolving pneumonia is defined as presence of persistent clinical symptoms or sign. I have already mentioned that the patient is failure to improve clinically. Ki clinically signs dekhbi failure for improvement? First, fever is persisting, tachypnea is persisting, or the patient is still hypoxic or hypotensive. And sputum cough with more sputum production, failure to resolution of the radiographic feature by 50% in 2 weeks, or completely in 4 weeks, or on serial chest X-ray, in spite of antibiotic therapy for minimum duration of 10 days. এটা কিন্তু ইম্পর্টেন্ট, যে আগে রেকমেন্ডেড ছিল 10 days, but now the recommendation is for 7 days, after 7 days. So these are the etiologies of non-resolving pneumonia. This is very important. Unusual infections like fungal infections. If the pneumonia is fungal, what are the most common fungal pneumonias? Pneumocystis. Second, Aspergillus, right? And these two are the most common, pneumocystis and Aspergillus. And immunocompromised individual in case of mycobacterium tuberculosis. একটা পেশেন্টের হয়তো টিউবারকুলোসিস হয়েছে, তাকে তো এই ড্রাগগুলো দিয়ে কিছু লাভই হবে না। So this is the criteria of non-resolving pneumonia, etiology. And if there is a neoplasm, bronchogenic carcinoma or lymphoma, or immunological disease like the patient is having vasculitis or rheumatoid arthritis or any rheumatological disease, connective tissue disease, or alveolar proteinosis, sarcoidosis. So what are the complications of pneumonia? Local complications, lung abscess, empyema, and necrosis to hoy na, necrosis hoy to lung abscess hoy, parapneumonic effusion and pneumothorax. Pneumothorax, যে pneumonia that are cavitary pneumonia, cavitary that produces cavity, যে নিউমোনিয়া থেকে ক্যাভিটি প্রোডাকশন হয়, যেমন ক্যাভিটি কোন নিউমোনিয়া থেকে প্রোডাকশন হবে, দোজ নিউমোনিয়া আর নেক্রোটাইজিং ওয়ান, হুইচ আর দ্য নেক্রোটাইজিং ওয়ান, স্ট্যাফ অরিয়াস, ক্লেপসিয়েলা, সিউডোমোনাস, অ্যানারোবিক. So these four are the necrotizing pneumonia or cavitary pneumonia. Tuberculosis. So cavitary pneumonia থেকে lung abscess এর চান্স বেশি হয় and pneumothorax এর চান্স বেশি হয়, because cavity rupture করলে pneumothorax হবে. Okay, and also pneumocystis. Pneumocystis also produces cavitary pneumonia. So systemic complications are respiratory failure, septic shock, right? And multi-organ dysfunction syndrome, metastatic abscess, septic arthritis. So septic arthritis most commonly কোন নিউমোনিয়াতে হয়, Staph aureus, and infective endocarditis also Staph aureus. So lung abscess, আবার একবার ডেফিনিশনটা বল lung abscess এর. So localized area of parenchymal tissue, parenchymal destruction leading to necrosis due to pyogenic organism and formation of a cavity. So there are two types of lung abscess, there is primary or secondary, and according to the duration acute and chronic. Okay, so primary lung abscess is due to aspiration, aspiration hole primary hobe, আর secondary is due to other bacterial causes. কি কি causes হতে পারে, post obstruction or post infective, post obstruction or post infective, and acute is less than 4 weeks, chronic is more than 4 weeks. So aspiration pneumonia is mostly chronic one, aspiration lung abscess is mostly chronic one, because aspiration একদিনে তো হয় না, aspiration chronically হয়, micro aspirate হতে 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 ultimately accumulates, the aspirated organism accumulates in parenchyma, they destroy the parenchyma, and which results into formation of lung abscess. So it is chronic process. So this is what is the pathophysiology of primary lung abscess, just like aspiration pneumonia. So anaerobic organism in oral cavity, chronic aspiration which leads to chronic infection of lung parenchyma by anaerobe, followed by parenchymal destruction, formation of cavity and lung abscess. And secondary lung abscess, কিছু idea pathophysiology, secondary lung abscess is due to obstruction, post obstruction, একটা bronchus connecting bronchus আছে, সেই bronchus এ একটা obstruction by foreign body or tumor, so that leads to stasis of the secretion. So এই stasis হওয়ার জন্য ওই এরিয়াতে necrotizing inflammation হচ্ছে by invading organisms, তাই তো, because ওখানে bacterial load is more, because ওখানে অনেক দিন ধরে stasis হয়ে আছে organism, that leads to destruction of the parenchyma and formation of cavity lung abscess. So this is post obstructive lung abscess. And seeding of septic emboli from infective endocarditis or osteomyelitis. So diagnosis just same as of the pneumonia part, but এখানে most important is the expectoration is foul smelling in case of anaerobic organism, and most importantly the expectoration is posture dependent. Why posture dependent? Patient বলবে যে আমার particularly left or right lateral position এ গেলে আমার expectoration বেড়ে যাচ্ছে, right? Why? Because a particular bronchus is affected, তাই তো, particular bronchus is affected, so যে ওই bronchus এর যে dependent position হবে সেখানে তার secretion বাড়বে. So this is typical of abscess, lung abscess. So this is an X-ray of lung abscess. These are the typical sites for lung abscess. This is lower lobe, anterior segment of lower lobe, and this is posterior segment of the upper lobe. But this is not an usual site, this is left side. left-sided abscess is not the usual and is not common, right? So if you encounter a lung abscess that is in his unusual site, maybe left side or maybe right middle lobe or right lower lobe, then তোকে কি করতে হবে? You must to do a CT thorax, because unusual site of lung abscess যদি হয়, there is every chance of malignancy is there, ঠিক আছে? Second thing is that কি তোর লাং অ্যাবসেসের যেটা খুব ইম্পর্টেন্ট সেটা হচ্ছে ওয়াল থিকনেস অ্যাসেসমেন্ট করতে হয়। ওয়াল থিকনেস অ্যাসেসমেন্ট, দেখ এইখানে এই লাং অ্যাবসেসের দিস ইজ দ্য ওয়াল, এটা তো ওয়াল, বুঝতে পারছিস তো ওয়াল, বাট এই লাং অ্যাবসেসের ওয়াল দেখ, দিস ইজ অবভিয়াসলি থিক and this is in unusual site, so this is a malignancy. So sputum gram stain culture, fungal stain or AFB stain followed by CT guided aspiration, especially in case of CT guided aspiration সবার জন্য নয়, or CT guided biopsy is not for every lung in each case of lung abscess. So specifically smoker more than 40 years, having weight loss or hemoptysis, thick wall cavity and atypical sites, এইগুলো যদি থাকে তাহলে you should order CT guided FNAC from the abscess wall to exclude malignancy. So in case of primary lung abscess, that is mostly due to aspiration. So what would be the initial treatment? Drug of choice. What is the drug of choice of anaerobic lung abscess? Clindamycin. So duration would be, so injection clindamycin 600 mg thrice daily, followed by oral clindamycin 300 mg thrice daily. So injection clindamycin for mostly 7 days and after that switch to oral clindamycin. For duration would be minimum 7 days but maximum আমরা যে কটা অ্যাবসেস পাই ম্যাক্সিমাম তারা ক্লিয়ার হয় কিন্তু 14 to 21 days এ, রাইট? সো দ্য রেস্ট অফ দ্য ডেজ তাকে কি করতে হবে? ওরাল থেরাপি দিতে হবে। সো ইন কেস অফ অ্যান্টিবায়োটিক ট্রিটমেন্ট ফেলিওর কেসেস ইউ মাস্ট ডু লোবেক্টমি, লোবেক্টমি করতে হবে। যদি অ্যান্টিবায়োটিক ফেলিওর হয় তাহলে লোবেক্টমি করে ওই ড্রেনেজ, ওই পার্টটাকে ড্রেনেজ করতে হবে। ওকে, সো দিস ইজ এ ডেফিনেটিভ ট্রিটমেন্ট।